So the management of GBM is also what I'm a part of on the brain tumor board. Preoperatively, we get a full brain MRI, and we also throw on what's called a stealth image. And the stealth image is really for when the neurosurgeons are in the OR and they have a frame on top, and they use that to guide them into where the tumor is. When they're looking at it from the outside, obviously, you know, even after they've gone in through the skull, it's very difficult for them to know exactly how to approach this tumor. So that's why they do this stealth. It's a very thin section, high resolution image. We can also do what's called MR tractography here at Monmouth, and I'll show you some pictures about that. That can help the neurosurgeons guide their approach as well. After that, we have a postoperative day number 1 scan. We do follow-ups initially at 2 to 3 months, and then further follow-up as needed. And then obviously if there's any new symptoms that pop up, we can do scanning either with a CAT scan or an MRI. So let's start off with a preoperative scan. If we just take this patient, for example, there's a mass with rim enhancement here. My first diagnosis would be GBM, all right? So they're going to do a stealth protocol MRI along with MR tractography. I just want to briefly cover MR tractography. As you look at this slide, water is basically pretty disorganized. Yeah, you guys have all done in high school the food coloring into water and it diffuses. That's the disorganized water. But water that's along neurons is organized. And MRI has the ability to look at that motion of water. So if you look at these images here, all of the water that's going front to back here is in green. All the motion of water that's going right to left is in red. And then all the motion that's going up and down in the brain is in blue. So from these images, we can put together tracks, neuron tracks that go through the brain. So what's the utility of this? Look at here. So you're looking at the patient's face here. And this is an imaging trick that we do, that we can kind of take off the front of the skull. Here's the brain tumor. And there are vital tracts that are coming up from the brainstem, which is here, up to the brain cortex. And those are things that you want to avoid as a neurosurgeon, to preserve motion and to preserve speech oftentimes. All right? So that's one of the things that we can do here is MR tractography. So postoperatively, we see this patient. Patient's had a craniotomy here. You can even see some skin staples. Underneath that, remember the ring enhancing mass that was there? It's gone now. All right, and there's a cavity that's there. And the cavity is clean. And that's what we want to see. We don't want to see any residual tumor there. So this patient was followed at 2 to 3 months and then even further. And we can see this resection cavity is still clean. So this is a great outcome for this patient. Let's take a look at a different patient now. So this is patient number 2. The patient's also had a craniotomy. In the resection cavity, you have a little bit of enhancement. All right, so we already started to worry about recurrence, right? That's a kind of a dreaded word, but recurrence is what we're looking for. And the patient was followed up just 1 month later, and already there's a big tumor there that we know is a recurrent tumor. Let's look at patient number 3, however, okay? So preoperatively, it looked like that other patient, ring enhancing mass. Postoperatively looks clean. 1 month following though, and this includes treatment, okay, and this is following radiation as well. You already have this enhancement along the margins here, and that's what you don't want. You want a resection cavity that either has very thin enhancement along the rim or no enhancement at all. So you're already starting to have this nodular enhancement along the margins. But when you follow it up, the nodular enhancement, and the patient was not reoperated, and there was no change in the treatment. You can see this tumor this enhancement is kind of going away on its own. So this is a phenomenon called pseudoprogression. Okay, so initially we have something that looks like progression or recurrence of tumor that actually turns out to be an inflammatory response that goes away by itself. This becomes a very tricky phenomenon for us to handle. So this is a patient on a follow-up scan. This is patient number 4. You can see this kind of enhancement in the back. Some of it may be blood products. So the question we have is, we know there's more enhancement. Which way is it going to go? Is it going to come down and stop, or is it going to keep on going up and become a real recurrence that needs to be reoperated on? Unfortunately, this patient turned out this was a real recurrence.